G'day, I'd like to let you know that Aussie Med Ed is sponsored by Tego. For most doctors, indemnity insurance is one of their biggest costs of practice. While many doctors are still with the same insurer they joined in medical school, many have made the switch to Tego and benefited from it. The team at Tego have told me that those new to private practice could qualify for 4 years of discounted premiums. To find out more about Tego, visit tego.com.au. That's tego.com.au. Over the last 3 years, Aussie Med Ed has covered many medical topics and multiple cancer issues, which include renal, colorectal, skin, lung and pancreatic. Whilst individual treatment varies between the specialties, in all cases, an oncologist is often required to assist in providing further treatment and to help reduce the risk of recurrence. Today we're going to learn more about what that oncology treatment involves. Welcome to Aussie Med Ed. Good day and welcome to Aussie Med Ed, the Australian medical education podcast, designed with a pragmatic approach to medical conditions by interviewing specialists in the medical field. I'm Gavin Nyman, an orthopaedic surgeon based in Adelaide, and I'm broadcasting from Ghanaland. I'd like to remind you that this podcast is available on all podcast players and is also available as a video version on YouTube. I'd also like to remind you that if you enjoy this podcast, please subscribe or leave a review or give us a thumbs up, as I really appreciate the support and it helps the channel grow. I'd like to start the podcast by acknowledging the traditional owners of the land on which this podcast is produced, the Kaurna people, and pay my respects to the elders both past, present and emerging. I'd like to remind you that all the information presented today is just one opinion and there are various ways of treating all medical conditions. Therefore, you should always seek the opinion from your health professionals in the area in which you live. Also, if you have any concerns about the information raised today, please speak to your general practitioner or seek advice from a health organisation such as Lifeline in Australia. Well, it's my pleasure now to introduce Professor Tim Price. He trained in medical oncology at the Royal Adelaide Hospital and completed a gastrointestinal fellowship at the Royal Marsden Hospital in London. He's currently head of clinical oncology research and head of unit of the combined haematology and medical oncology service at the Queen Elizabeth Hospital, and holds visiting positions both at the Calvary Hospital North Adelaide, Western Hospital in Henley Beach, as well as the Lyell McEwen Hospitals. He's a clinical professor within the Faculty of Medicine at the University of Adelaide. Along with all these accolades, he's also well known as being one of the nicest guys around the hospital. Welcome, Tim.
Thank you. Thanks, you, Gavin, for inviting me, and I'm a pleasure to talk about medical oncology today.
It's fantastic to have you on board. Look, I thought I'd just start off by asking you what your job involves. When I did my little bit of research, I realised how expansive it is. Perhaps you can describe it for the medical student and the GP who's listening.
Yeah, currently I have a few different roles, which is what you're probably alluding to. So I'm a medical oncologist, so I obviously see patients. I have 2 clinic days a week. I also am the head of the clinical research unit within the cancer centre here at Queen Elizabeth Hospital. So we run the clinical trials. And then I'm also currently involved in what's called the Bragg Comprehensive Cancer Centre, which is developing a comprehensive cancer centre for South Australia, which is part of a national drive to have what are called comprehensive cancer centres across the nation. So that's my various roles at the moment. I'm also involved in the Australasian Gastrointestinal Trials Group, which runs gastrointestinal trials across Australia. So my main interest is in gastrointestinal cancers.
Well, thank you very much for sparing some time.
No problem.
Well, an oncologist, from my point of view, is someone who treats or looks after all the adjuvant and neoadjuvant therapies for cancers. And when you look at the different cancers that we've seen, in Aussie Med Ed, we've actually covered breast, renal, lung, prostate, melanoma, and all the individual specialists have to know those in quite deep detail. But you as an oncologist need to know all of them in perfect detail. How do you manage to learn all of this?
Yeah, so it's actually a good question because it is actually currently changing in terms of the way medical oncologists work. As you alluded to, there are different cancers within the community. Breast cancer, colorectal cancer, prostate cancer in particular are the more common ones that are important to understand. And within that, there is now a great degree of complexity around the different treatments. So we'll talk a little bit later about some of those treatments. But within colorectal cancer, for example, there are now at least 6 defined subgroups that all have different treatment pathways. For example, myself, I'm primarily a gastrointestinal medical oncologist. So that's all I do. So that's from the esophagus through to the anus. and everything in between. And there is a lot of different treatments involved. Now, there are some medical oncologists who are generalists who, as you say, have to treat all cancers, but that's becoming increasingly less common. Most oncologists will either have a fairly large tumor stream, which gastrointestinal is, or they may do breast cancer and gynae cancer, for example. So it is not quite as broad as you're concerned in terms of the breadth of knowledge needed. It's a bit like in your specialty, orthopedics. I mean, there are now knee specialists, hand specialists, etc. So it is becoming subspecialized even within the specialty.
Right. And when does your role start? Does it start from initial diagnosis when a specialist refers a patient to you and you join a multidisciplinary team?
Yeah, so the commencement of meeting a patient with cancer is very variable. So it may be a referral directly from the GP. So, for example, they may find that they've done a scan and there's a lesion in the bowel and also, unfortunately, metastases in the liver. And that patient may be referred directly to me. And then I will then, as you say, coordinate that multidisciplinary management, which will, of course, include a surgeon and sometimes a radiation oncologist. A lot of the referrals, though, have come via the surgeon. So the GP will have picked up bowel symptoms. Bleeding, for example, is a common one for colon cancer. And they'll have had surgical workup, diagnosis, potentially surgery, and then they'll come to the medical oncologist to consider the chemotherapy part of the treatment. It is a fair point to make that the medical oncologist often has the most prolonged contact with the cancer patient. So a surgeon will operate, recover. That might be a few weeks, but a medical oncologist can be 6 months if they're having adjuvant therapy, and it could be lifelong if they're having treatment for more advanced disease.
And who do you depend upon predominantly as part of your support team?
Yeah, so the crucial team within a medical oncology unit will be the chemotherapy nurses are particularly important because obviously that's what our main tool of our trade is, delivering chemotherapy, and particularly intravenous chemotherapy. Highly trained chemotherapy nurses who understand the treatments, side effect screening, and just being there to deliver the safe chemotherapy access and so forth. The other crucial thing in today's practice is what are called cancer care coordinators, or sometimes they're termed nurse navigators, but that can be more broad in terms of different specialties. But they're really increasingly important because of the multidisciplinary nature of cancer care. So patient may have a medical oncology appointment, they may have a surgical appointment, radiation. And for a patient, coordinating all those appointments, understanding why they have them, trying to make sure they flow with their investigations. So often they'll have CT scans, different x-rays. And so navigating through and coordinating that sort of sequential approach so that the management flows, there's a pathway, is often importantly guided by those cancer care coordinators or nurse navigators. I mean, more broadly, cancer is a upsetting diagnosis. So psychologists are really important in the cancer center. Dietitians are really important because with particularly more advanced cancer, the nutritional changes that can occur because people don't have an appetite and weight loss, and trying to manage that. And then, of course, patients are admitted to a ward and often have cancer-specific symptoms. So having cancer-trained nurses on a cancer-specific ward are also important. So there's so many different specialties and clinical practitioners that are involved in the care of cancer. And I guess just as I'm talking through, the other one is nowadays increasingly is physiotherapy or exercise physiologists. So trying to maintain, we know exercise has a positive impact on cancer outcomes, particularly in breast and colon cancer. And focusing on that exercise and keeping people well and active is also increasingly important. So there's lots of people that are involved in that cancer team beyond our surgeons and radiation oncologists.
I suspect the palliative team will also have a role at some stage in some of those patients, hopefully not as many as we might think.
Yes, so that's a very important point. As you alluded to with the way you asked the question, patients ideally will be on chemotherapy and tolerating that, will be keeping their disease under control, which nowadays can be for years rather than months. Historically, advanced disease was often measured in months in terms of median survival. Nowadays, it's often in many years. So those patients remain well, and we need to manage their symptoms and side effects. But as the treatments start to become less effective or patients become resistant to treatments, then the palliative care team becomes a crucial partner in managing those patients as they develop symptoms, particularly pain, weight loss, nausea, which is probably what precipitated your question, because they are symptoms of the later phases of cancer. So yeah, we work closely with palliative care, particularly towards the later part of patients' pathway. And then often that is a transition to palliative care being the primary caregivers. That said, the general practitioner can be incredibly important in that phase, not only through the whole pathway of cancer treatments and support, but particularly in those later stages when patients are having symptoms and the general practitioner understands the family. They may have known that patient for many years, the husband or wife, etc. So I think it's a partnership of a number of different teams, but certainly palliative care is very important.
Yeah. When I think about treatment of cancer, I think of surgery, oncology, and radiotherapy. Are there any other modalities I need to think about part of the treatment process of cancer?
So just in terms of the definitions there, it's really important to sometimes define that. So adjuvant therapy, neoadjuvant therapy are primarily in the curative setting. And in that setting, often surgical intervention and radiation intervention are core component of that whole treatment pathway. So the adjuvant is obviously when patients have had surgery, either their breast cancer removed completely, and then adjuvant therapy is aimed at reducing risk of future recurrence based on micrometastatic disease that we can't measure. I guess to your question about what are the other things we need to be aware of, so that just makes me think of the new sort of novel technique of looking for circulating tumour DNA. We're probably going on a little tangent to your question, but in terms of new technology, what is increasingly being explored is whether you can actually tell which patient requires adjuvant therapy. By definition, a patient who comes to you to discuss adjuvant therapy is not because they definitely have cancer. It's a potential that they may have microscopic disease. And then you're giving all of the patients you see, of which there may be, let's say, for example, there's a 30% risk that they may have microscopic cells that cause a problem in the future. But you'll see 10 patients. There'll be 3 who may benefit because they're at risk and the other 7 won't. But all of those patients are getting chemotherapy. So that's a fair proportion of patients who are getting chemotherapy for essentially no reason at all. So what we're now seeing is that we can potentially differentiate between the 7 who do not require it and the 3 who do by measuring by what's called a liquid biopsy, seeing whether there are circulating tumour DNA measurable, which then indicates there's residual disease. And those patients then would ideally then be advised to have adjuvant chemotherapy. And if we can show the reliability, the sensitivity of those tests, it is still very investigational, but the sensitivity and specificity is increasing. Ultimately, we should be able to do a blood test, if you like, to then tell whether a patient actually needs adjuvant therapy or not. So that is a significant change. In terms of, I think you're asking around what's sort of changing that multidisciplinary space. The other thing that comes to mind in terms of a major change in my specialty is that patients who have low bowel cancer, rectal cancer, for example, if you think of bowel cancer, the typical response would be you need an operation or surgery. For rectal cancer now, what we now do is look at a combination of chemotherapy and radiotherapy as a neoadjuvant, so pre-surgical intervention in the curative setting, and then an additional round of chemotherapy, so roughly 5-6 months of therapy. And what we can see is that around 40 to 50% of patients actually have a complete response without needing surgery. So preserving the rectum is now becoming increasingly an option for patients who have rectal cancer. So that's quite a different way of practicing. So historically, they would have gone straight to surgery, or they may have had some radiotherapy before, but then always had surgery. And now nearly half of patients potentially may actually not need to go to surgery. And of course, for rectal cancer, the requirement of a stoma and the impact on the patient is really quite significant. So that's a major change, looking at the whole 3 specialties. So radiotherapy, chemotherapy, and then potentially, in fact, not needing the surgeon aside from very close surveillance after that. So that's one of the key things I'd say. The other way of answering your question is looking at beyond chemotherapy. So in that adjuvant setting, so in that precautionary post-operative setting, the other big change is particularly in melanoma, where now we know that immunotherapy, which has been a game changer for melanoma overall, but even in the adjuvant setting, we're now seeing that we can prevent recurrence. Melanoma, when it recurs, historically is not a good thing, although immunotherapy has changed that as well. But we now can give adjuvant removal of a melanoma lesion, immunotherapy, and then there's a significant reduction in the risk of then recurrence in the future. So that's a big change. It's not just chemotherapy given in the adjuvant therapy setting, it's also immunotherapy. And then there are some other targeted agents that are what are called targeted agents, which are also used in the adjuvant setting for lung cancer, for example. So yeah, it has moved beyond just standard chemotherapy. Yeah.
Right. I mean, in the years since I've trained, the stuff you're talking about is just like science fiction when I went through, and it's just amazing you can do that. I'm in awe of how things have progressed. What agents do you generally tend to use when it comes to chemotherapy? And are there a few ones that the medical students and GPs should know as the broad headings, just the basics?
So I think what I would suggest is important is really understanding the differentiation today between chemotherapy, what are often called molecular or targeted agents, or immunotherapy. Because if you have a patient who presents to your clinic or into emergency, identifying the differences between those is really important in terms of particularly the potential side effects and how they're managed. So if we start with chemotherapy, there are lots of different mechanisms of how chemotherapy work. They can be direct DNA damaging agents, or they might impact on the cell cycle. But ultimately, they're cell killers. They're essentially killing the cancer cells by whatever mechanism they're delivered. And therefore, they typically have fairly broad, recognizable side effects, which are important to understand. The risk of nausea, which nowadays is actually far less because we have medications to prevent that. But the risk of gut toxicity, so diarrhea, mucositis is pretty common. Alopecia is what we always realize, but that's actually very dependent on the type of drug. So anthracyclines, for example, will cause hair loss, as would what we call taxanes. That's another class of agent. But essentially, alopecia is one side effect that we need to be aware of. But particularly in terms of managing things, gut toxicity is one. So mucosal damage from the chemotherapy, the toxicity, and obviously hematological toxicity is the other one that's very important to be aware of with chemotherapy. So when someone presents with, they say they're on chemotherapy and they have a fever, it's very important to understand what their white cell count or their neutrophil count is, because if they have neutropenia, then their risk of sepsis and potentially dying from that is actually then quite high untreated. So the need for early intervention, early intravenous antibiotics for someone who's neutropenic and has fever is very important to understand. Fatigue, all of those sort of other general side effects are important. I guess they're the key ones that you should always be aware with chemotherapy. And I think chemotherapy has been around for many years. I think most people know those key side effects and potentially know how to manage those. The ones that are different, though, are particularly immunotherapies. Immunotherapy does not cause typical chemotherapy-like side effects. Essentially, the main side effects of immunotherapy are autoimmune processes, inflammatory bowel-like syndromes where you get colitis from an autoimmune process. Hypothyroidism, hypophysitis is actually quite common with immunotherapy, needing thyroid replacement or cortisol replacement, for example. Pneumonitis, hepatitis, all from an autoimmune mechanism are the side effects that you see with immunotherapy. And essentially, they all have the same treatment, which is steroid. So as you would with a autoimmune disease, the crucial thing is to recognize that someone who's on immunotherapy and potentially has a autoimmune process needs steroids, and they often need them in high dose and ideally need that early. So that's a really important understanding broadly as to what you need to think about when someone has immunotherapy. And unusual toxicity, so myocarditis, pericarditis, those sort of things. So if patients present with syndromes that you might think are a diagnosis, but it's linking that to that autoimmune process and then starting steroids, which is really important. And then the molecular drugs often have fairly specific side effects depending on the class. For example, there are what are called anti-EGFR or epithelial growth factor receptor antibodies. Patients will often confuse those and call them immunotherapy, but they're not. They are antibodies against growth factors. And they have, for example, a particular side effect with a rash, and it's often an acne-like rash. So it's often facial, chest, requires steroid cream, antibiotics, and advice about sun and creams. And so that's an unusual side effect, somewhat unexpected. and certainly not one you'd see with chemotherapy, and is specific to that class of agent. Some of the other drugs have other types of rash. Some drugs cause a lot of arthralgia, joint symptoms, and they require physiotherapy. And so I guess just being mindful that there are these differences between standard chemotherapy, which often cause people think about diarrhea, effect on blood counts, nausea, fatigue. That's chemotherapy. Immunotherapy is very much autoimmune processes, which have a very specific treatment, as in steroid. And then some of the other sort of what are called targeted drugs have relatively specific side effects depending on what the target is. So the reason the anti-GFR drugs cause a rash is that the receptor is actually quite common in the skin. And in fact, the rash is a good signal that the drug is working. So if you get a really bad rash, it's probably working because it's hitting the target. But it is a distressing symptom, and it's a shame it has to occur, but it is one specific to that sort of target. The other one, which is quite common, are what are called anti-angiogenic drugs. So they're targeting the vascular endothelial growth factor. Those drugs cause hypertension and proteinuria. So they're, again, someone who's on a anti-angiogenic drug and might turn up to the clinic or to emergency with very high blood pressure. It's important to identify that probably related to their chemotherapy treatment. So again, it's not one that you would think of as being chemotherapy. It's related to the targeted drug, and because it works on blood vessels, and then managing that hypertension somewhat aggressively is appropriate because it is drug driven, and the antibodies have longer half-life, so it's not going to go away quickly. So they're just a few examples of the different agents and then therefore the different side effects that we need to be aware of. So it's not just classic chemotherapy anymore with those typical side effects. There's a number of differing side effects we see from those different types of drugs nowadays.
Brilliant. Great summary. Thoughts come to mind. When a patient presents to casualty and is assessed by an intern or comes to a GP practice and they've got neutropenia from a chemotherapeutic agent, how do you determine it's actually a sepsis? If they've got a high fever but you can't see a raised white cell count, they may not have a ESR or CRP response because of their reduction in the cells and things. Apart from being aware of it and just treating it on spec, are there any other things that these doctors should look out for?
Yeah, so the crucial message that there is that if a patient presents with a fever and you've done a blood count and let's say their neutrophil count's 0.3 or 0.2, the crucial thing there is that irrespective of whether they're unwell or not, they should go probably to their cancer centre or to emergency because they are at risk because they've already had a fever. Obviously, something's going on and they need then to be assessed and potentially put on intravenous antibiotics. Now, there are protocols, sorry, I'm slightly diverging from your question, but there are protocols for what are called low-risk neutropenia, and sometimes patients can be sent home with oral antibiotics, but it does depend on the protocol. So how long you predict the patient will be neutropenic. So the longer, if a particular chemotherapy protocol means that you're likely to be neutropenic for a prolonged period of time, you would always admit that patient for intravenous antibiotics. There's a high risk that fever is predicting for deterioration. So I guess that's the crucial message. If someone has a fever, even if they're not unwell at the time, they probably need to have assessment at the cancer centre because they're at risk of deteriorating. In terms of telling the sepsis, there are the classic symptoms are still there. If they're developing hypertension, tachycardia, etc., they would be the clinical findings. The other point to make sometimes, though, is that if a patient on chemotherapy presents unwell, and particularly unwell, and then they're neutropenic, they may in fact not mount a fever. So they might be hypothermic, which again comes back to your question about sepsis. So those patients are obviously at very high risk of deteriorating. So CRP generally does still become elevated in the setting of infection, even if you are neutropenic. So those investigations are still relatively informative. But obviously the crucial thing is understanding that neutropenia. Yeah.
The other question that comes to mind is with the use of immunotherapy, you talked about an autoimmune reaction. Now, obviously, rheumatologists treat these autoimmune type conditions nowadays with biologic agents. Can you use the immunotherapy and then a biologic agent to treat the autoimmune reaction, or you still stick with the standard steroids?
You're absolutely right. So the first line therapy is steroids, and often, as I mentioned before, high dose steroid. But then if you have an autoimmune persistent colitis, then that's right. You can come in with some of the other agents that are used for inflammatory bowel disease, for example, and rheumatoid, etc. So they are the next step up. They're relatively expensive and has complicated the way we treat some of these toxicities. And so I guess one of the other things to talk about, which is actually quite important around modern treatments for cancer, is the financial toxicity of some of these agents. So they're not always available on the PBAC. So we need to then work with how we fund these agents, and immunotherapy historically has been very expensive. And then you add in a toxicity that then has, if you don't respond to steroid, a very expensive biologic to try to treat that autoimmune syndrome. That makes things quite complex, particularly as patients are generally admitted to the hospital, and then the funding, the budget around trying to support the immunotherapy toxicity has been something that's been of concern of recent years. That said, the new generation immunotherapy drugs have far less common risk of these autoimmune conditions, and therefore the need for some of those biologics is less. But you're right, steroid and then a biologic if that's failing.
And going back to the nausea agents we're talking about, is ondansetron still the one that's predominantly used for chemotherapy and other nausea conditions associated with this, or is there newer agents again?
Yeah, so there's NK inhibitors, which is a different class, and then there's the ondansetron or palazestrant, but they're the same class as ondansetron. And now there's actually a combination of the NK inhibitors and ondansetron-like drugs, which we give pre-chemotherapy, and then that's often combined with steroid, with dexamethasone. So it's really what you'd call a triplet combination of drugs to minimize the risk of nausea. Nowadays, nausea becomes less of a problem. And in fact, what we see more often is that patients complain of the post-chemotherapy fatigue or tiredness for 2 or 3 days after. And I think it's because the nausea is better controlled that probably fatigue's always been there, but that's really what they now notice. And that's, so those new anti-nausea medications have really changed things. Just going back to one of the earlier questions around side effects and what clinicians should be aware of, it just made me think about neuropathy. Nausea we've controlled. Even alopecia nowadays, we have cold caps to reduce that risk. But one of the more concerning, longer persistent side effects of chemotherapy is neuropathy, and certainly cisplatin, so the platinum class drugs can cause neuropathy. But a drug that I use commonly, oxaliplatin, it's a very effective drug for bowel cancer, and in fact all GI cancers nowadays. But it has this risk of causing an unusual cold sensitivity, so that if you touch something cold or walk on cold tiles or even drink a cold drink, it feels like your throat closing up or you've got pain in your hands and feet. And that can transition into actually a painful peripheral neuropathy that persists. And that can be quite problematic. And I think a lot of general practitioners see these patients who have had their treatment and they're in their, if you like, their survivorship period, and they come with that neuropathy and they're obviously wanting some answers and some treatment. And unfortunately, in some patients develops into an irreversible, uncomfortable neuropathy, which in fact has no treatment. And there's been a lot of investigation research around trying to prevent that neuropathy, giving calcium, magnesium infusions, for example, using early anti-epileptic drugs to see if it reduces the neuropathy. But unfortunately, it's a very persistent problem. It's one that I see general practitioners refer patients back for, is there some way we can improve this? And unfortunately, there's not. So that being aware of that neuropathy, I think, is probably also something that would be useful. Yeah.
On that aspect, obviously, sometimes, not commonly, but occasionally we'll see a patient for carpal tunnel or some other nerve entrapment type condition who is having chemotherapy. Is that contraindicated to do a release, or would you still recommend trying a release to try and help as much nerve entrapment as possible in that situation?
Yeah, if they've got a separate syndrome like carpal tunnel, then that would certainly be appropriate to manage that as necessary. And I guess that's why I mentioned that neuropathy, because it is a side effect that's out there. It tends to resolve, but try to differentiate between the chemotherapy neuropathy that may be persisting and then other syndromes, as in carpal tunnel, is really important.
And does that neuropathy affect the optic nerve as well? Obviously, it's more of a central nerve or cranial nerve.
No, so it's purely a peripheral neuropathy. Now, that said, delving into the less common here, but when you have an oxaliplatin infusion, as I mentioned, this cold sensitivity comes on quite quickly. It can be a very difficult drug to give in winter, for example. I think if you lived in the UK, it would be a terrible drug because it's always cold there. But if you go from the warmth of the chemotherapy suite and you go out into the cold, you get this cold air into your mouth and it feels like it's closing over. you get the hands and feet. But some people do get some funny jaw symptoms. Some people get some visual changes. So going back to, it doesn't affect the optic nerve, but it creates this sort of sensitivity, which I think is not well understood. It's transient, goes away. And in fact, some people develop some tongue symptoms. They have a bit of trouble with their speech. And then some patients even describe this sort of jelly legs. They physically can't actually walk and they need to stay in overnight. It all goes away, but there is some unusual sort of spectrum within this sort of nervous system effect that oxaliplatin causes, but typically it's that cold sensitivity.
You're predominantly gut oncology. How often would you need to see a patient after a diagnosis with a gastrointestinal cancer? And what's the sort of normal follow-up period, and how do you evaluate them when you do see them?
Yeah, so it depends a little bit on the situation. So an adjuvant patient, for example, will come to us after their surgery. They'll then have generally 3 to 6 months of chemotherapy as an adjuvant precautionary treatment. And then generally those patients will then go back to their surgeon for surveillance. And that might be the colorectal surgeon or the breast endocrine surgeon, if it's a breast cancer, etc. If a patient has metastatic disease, then they're probably going to see you for a long time. In the metastatic setting, what would be termed palliative chemotherapy schedules will be given. And when I use that, it's very important to understand that it's just the terminology. So we're not in a palliative setting, but because they're aimed at controlling disease, controlling symptoms, preventing symptoms, etc. That's the terminology. And so in that sort of setting, patients will have a course of chemotherapy, which is generally about 6 months. Then hopefully they're in a type of remission or disease control, and they'll be monitored. They'll then have regular scans every 2 to 3 months. And then when they have activity again, they would recommence the chemotherapy schedule. And you'd be seeing patients roughly every 3 months when they're not on chemotherapy. During chemotherapy, though, it will depend on the schedule. So some chemotherapy schedules are every week, some are every 2 weeks, and then some are every 3 weeks. That's probably the biggest gap. And then you would see those patients essentially before each chemotherapy. You assess their blood count. So going back to the neutropenia point before, you would need to make sure that they've had hematological recovery. So their neutrophil count and platelet count is adequate. And then they would proceed with chemotherapy.
I think you basically touched upon the newer agents, but where are things heading? What's the innovations that are coming in the area of oncology treatment? Is there anything on top of immunotherapy and other agents that you've talked about already that's actually quite exciting?
Yeah, so the other sort of class of drugs that are coming through are what are called ADCs, which are antibody drug conjugates. And they're quite interesting in that they're basically an antibody to a receptor that's quite common on a cancer. So the antibody is not the treatment part. So the antibodies I talked before, the EGFR or the vascular factor I described before, the antibody is directed at those receptors as part of its treatment mechanism. The antibody drug conjugates are drugs that will bind to a receptor that's not necessarily related to the cancer process, but it's common on a cancer cell. It may be overexpressed, but not necessarily driving the cancer. And then there's what's called a drug payload. So to the antibody is then linked essentially a chemotherapy drug.
A heat-seeking missile.
Exactly. So what you're doing there is you're trying to deliver the chemotherapy drug directly to the cancer cell by using the overexpressed antibody. Now, in theory, those drugs will be more targeted. It is still chemotherapy. It's still cytotoxic, killing those cells. But it is, yes, exactly, so as you described. So that's one exciting change that's been occurring. The other one is what's called CAR T cells. Now, this is more commonly used in hematology, but is increasingly being used in solid cancers. It's a type of immunotherapy, and again, based on the particular receptors or behavior of certain cancer cells. For example, there are CAR T cell trials for bowel cancer. They are particular bowel cancers that have particular receptors, which then allow the T cell, manipulated T cell, which is part of a CAR T infusion, to then be delivered to again hone in on those cancer cells. Cancer vaccines. I had a patient who chose to travel to the US, to the Mayo Clinic in the US, to have a personalized vaccine developed. Now, I'm not quite across the technology of some of these things because they're really now getting into the field of true immunology, specialized cancer therapy, and there are particular clinicians who do that, particularly the hematologists. But it is looking like CAR T therapy and vaccine therapy, personalized vaccine therapy, will have a place in the solid cancer setting. And that's a very strong area of research moving forward. And so I guess they're two examples of technology that's really developing, becoming quite intricate and complex around the understanding of the cancer cell and the individual's immune system, and then trying to use that to drive the therapeutic approach. They would be the two changes that would come to mind. And then there are changes to just immunotherapy. As I mentioned before, they're a first generation, they're a new generation of drugs. As we understand how we manipulate the immune system, immunotherapy essentially turns our immune system back on. That's essentially what it's doing. So we're actually fighting the cancer off ourselves by having these antibodies turn our own immune system back on, or stopping the process that occurs where the body becomes fatigued. So we have lots of abnormal cells in our body all the time, but we often clear those. If the population reaches a point where the immune system is overcome or fatigued, then it switches itself off. And what we need to do is then switch it back on, which is one of the key principles of immunotherapy. Understanding how we can turn that back on is really an important part of researching new generation immunotherapy.
Two questions come out of that. First one is, with the idea that normally our own immunology kills the cells that are floating around, but this new immunotherapy helps turn it back on. Does that explain why, as we age, risk of cancers get greater because we don't have as good immunity, and therefore we're not keeping the cancers in check, and therefore they can get out of control as we get older? Is that the thought that why it occurs, or is that just me making it simplified?
There's no doubt that is part of the process. Is the aging process itself, which puts the cells at greater risk of not repairing properly, etc. Greater exposure to carcinogens, etc. over time. But certainly that modification of the immune system is probably a factor in that as well as we age. Yeah.
And the other question that came into mind was the personalised vaccinations. Is that on the back of this mRNA vaccination that's come through from the COVID era, or was this well before all that?
Yeah, so the mRNA research that's come out of the COVID vaccine, I think, is increasingly a component of those personalised vaccines. As I mentioned, I'm not entirely across that technology because it is very highly specialised. Very few of those trials exist. As I say, my patient went to the US to seek out one of those. But there is various mechanisms of developing those personalised vaccines. They are very investigational. But yes, that's the interesting thing, isn't it? The mRNA technology was being investigated in the background, particularly around the cancer space. And then because of that, that's why it was being able to be transferred into the COVID situation so quickly, because it was a technology that was already understood and then transferring it very quickly. So we were lucky in a way that was being developed.
Excellent. My final question for you, but a year ago, we had an interview with a couple of researchers on artificial intelligence, and I thought there'd have to be a role of AI in your area for designing or working out which algorithms or which protocols work better for different patients. Is that the case, or is it not yet incorporated into oncology?
Yeah, it's going to be really interested where AI fits in terms of predicting or trying to guide a patient's pathway. Currently, it's relatively straightforward because it's based on those biomarkers that we get, mutation testing, etc. But I think where it's going to have a huge impact is in the diagnostic setting. You look at, so for example, for immunotherapy, we need to understand what's called the PD-L1 count, which is essentially what the antibodies for immunotherapy target. And so there are a number of different scoring mechanisms to give you your PD-L1 percentage on the immunohistochemistry of the specimen or biopsy. And that takes a lot of time. So the pathologist has to count a certain number of cells and then how many are PD-L1 positive. And I would think that AI training that occurs to be able to then read those pathology slides and give you a score will be a huge sort of time saving. A lot of the cost in some of what we do. So when you have a new drug that requires a PD-L1 score, that then requires funding for the pathologist to do that. If you can automate it, if you can just have it read, then some of those funding issues, which often delay our access to some of these interventions, can be overcome. Obviously, there's a cost of developing the AI, but I think there's a longer term trade-off in terms of something that can automate it. And then, of course, in the radiology field, I think that's the other area where AI is being seen, but that's predominantly around screening, particularly lung screening, for example, is coming into play, whether you can read the scan by AI. So I think definitely AI will have a place, particularly in some of the diagnostic settings, in terms of being able to, I guess the other part is, it's again diagnostic. So the molecular screening, when you look at these mutations, being able to look at this huge amount of data that comes out when you do a next generation sequencing, which is the NGS, which is the way the molecular testing is done, and looking for the mutations, the mutation count, burden. If that can be automated by AI, that's also going to give us a faster, I suspect, and also lower time intervention to get those results. So certainly in the diagnostic setting, I think there'll be a huge impact of AI. I don't think AI will take away from the clinical perspective of explaining what we need to do and those sort of things. Yeah.
It's been brilliant, absolutely brilliant having you on. I'm honestly in awe of what you're doing. It's fantastic hearing about it all, Tim. Really appreciate your time. You're a very busy gentleman. And once again, thank you very much for coming on Aussie Med Ed.
No worries. It's been a pleasure. Hopefully it's been of some interest. Thank you.
Oh, I'm sure it will be. So thank you very much. Thank you very much for listening to our podcast today. I'd like to remind you that the information provided is just general advice and may vary depending on the region in which you are practicing or being treated. If you have any concerns or questions about what we've discussed, you should seek advice from your general practitioner. I'd like to thank you very much for listening to our podcast, and please subscribe to the podcast for the next episode. Until then, please stay safe. Aussie Med Ed is proudly sponsored by HealthShare, a digital health company that provides solutions for patients, GPs and specialists across Australia, and TEGO, offering medical indemnity insurance for doctors. That's tego.com.au.